Cataract. The word cataract dates from Middle Ages, has been derived from Greek word cataractus, which means waterfall. This term was coined assuming that an abnormal humor developed and flowed in front of lens to decrease the vision. The present definition of cataract came much later, after understanding of the lens anatomy and of the fact that normal lenses are transparent structure. As of today, the term cataract refers to development of opacity, that is opacification of lenticles, lens or its capsule. Cataract thus may occur either due to formation of opaque lens fibers, congenital and developmental cataracts, or due to degenerative process leading to opacification of normally formed transparent lens. This is acute cataract. Two types only, so acquired or congenital. Clinically, the term cataract refers to an opacification of sufficient severity to impair vision. Etiological classifications. Congenital. First one is congenital cataract. Next is acquired cataract. Inacquired cataract, senile cataract, traumatic cataract, complicated cataract, metabolic cataract, electric cataract, radiation cataract, toxic cataract. Example: corticosteroid induced cataract, myotics induced cataract, copper and iron induced cataract, cataract associated with skin diseases, cataract associated with osseous diseases, cataract with miscellaneous syndromes, dystrophica myotonica, Down syndrome, Lewis syndrome, teacher Collins syndrome, etc. And morphological classification: capsular cataract. It involves capsule and maybe anterior capsular cataract or posterior capsular cataract. Subcapsular cataract. It involves superficial most part of cortex and includes anterior subcapsular cataract and posterior subcapsular cataract. Cortical cataract. It involves major part of cortex. Supranuclear cataract. It involves only deeper parts of cortex. Nuclear cataract. It involves nucleus of the crystalline lens. Then this is the diagram. Posterior subcapsular cataract, coronary and anterior cortical subcapsular, pyramidal, nuclear, lavender, posterior polar. Morphological shapes of cataract: polar cataract, anterior polar, posterior polar. This is the pole actually. This is the pole. So anterior polar and posterior polar cataract. Two types. Then let's see about the congenital and developmental cataracts. These are just basics. Congenital cataract. Congenital and developmental cataracts occur due to some disturbance in normal growth of lens, that is during the birth. So when the disturbance occurs before the birth, child is born with congenital cataract. When during development it occurs, that is during infancy and adolescence, it is developmental cataract. Therefore, such opacities may involve infantile or adult nucleus, deeper parts of cortex or capsule. Developmental cataract typically affects the particular zone which is being formed when this process is disturbed. The fibers laid down previously and subsequently are often normally formed and remain clear. Congenital and development opacity assume most variegated appearance, and minute opacities without visual disturbance are very common in most of the normal population. These are detected with beam of slit lamp under full mydriasis. Etiology is first one is idiopathic, that is the cause is not known in 33% of cases. Hereditary ones in hereditary cases without systemic disorders. This is the mode of inheritance is usually autosomal dominant. In hereditary cases with systemic disorders include chromosomal disorders, skeletal disorders, CNS disorders, renal disorders. CNS disorders include cerebello-oculofacial syndrome. Skeletal disorder includes Stickler syndrome. Renal system disorder include Lewis syndrome. Common Common familial cataracts include cataracta pulverulenta, jonular cataract, coronary cataract, and total soft cataract may also occur due to rubella. Maternal factors. Malnutrition during pregnancy have been associated with non-familial jonular cataract. Infections, maternal infection like rubella are associated with cataract in 50% of cases. Other maternal infections associated with congenital cataract include toxoplasmosis, cytomegalovirus inclusion disease, and drugs ingestion. Congenital cataracts have also been reported in the children of mothers who taken certain drugs during pregnancy, example thalidomide, corticosteroids, etc. Radiation. Maternal exposure to radiation during pregnancy may cause congenital cataracts. Fetal or infantile factors, deficient oxygenation, anoxia owing to placental hemorrhage, birth trauma, metabolic disorders of fetus or infant, such as galactosemia, galactokinase deficiency, cataracts with congenital anomalies, example as seen in Lewis syndrome, myotonia dystrophy, congenital ichthyosis. Ocular disease associated with development cataract include PHPV, aniridia, anterior chamber cleavage syndrome, retinopathy of prematurity, lenticonus posterior, microphthalmus. Malnutrition in early infancy may also cause developmental cataract. Congenital and development cataracts have been variously classified. A simple morphological classification of congenital and development cataract is as under: congenital capsular cataract, anterior capsular cataract, posterior capsular cataract, polar anterior, polar posterior, polar congenital nuclear cataract, cataracta pulverulenta, lamellar cataract, sutural and axial cataract, and in the floriform, coralliform, spear-shaped, anterior axial embryonic cataract, dendritic suture, total nuclear cataract, coronary cataract, blue dot cataract, total congenital cataract. Let's see about congenital capsular cataracts. First one is anterior. The congenital capsular cataracts. Anterior capsular cataracts are non-axial, stationary, and visually insignificant. Posterior capsular cataracts are rare and can be associated with persistent hyaloid artery remnants. Anterior polar cataract. It involves central part of anterior capsule and adjoining superficial most cortex. It may arise in following ways: due to delayed development of anterior chamber. In this case, the opacity is congenital, usually bilateral, stationary, visually insignificant. Due to corneal perforation, such cataracts may also be acquired in infantile stage and follow contact of lens capsule with back of cornea, usually after perforation due to ophthalmia, neonatum, or any other case. Morphological types. Anterior polar cataracts may occur as any of the following manifestation: thickened white plaque in the center of anterior capsule, anterior pyramidal cataract. In this, the thickened capsular opacity is cone-shaped with its apex towards cornea. Reduplicated cataract, double cataract, sometimes along with thickening of central point of anterior capsule. Lens fibers laying immediately beneath it also become opaque or subsequently separated from capsule by laying of transparent fibers in between them. The buried opacity is called imprint, and the two together constitute reduplicated cataract. Posterior polar cataract is very common lens anomaly and consists of small circular circumscribed opacity involving posterior polar cataract may be associated with persistent hyaloid artery remnants, Mittendorf dot, posterior anticonus, persistent hyperplastic primary vitreous PHPV, progressive form which progresses after birth. It typically has onion oval appearance. Cataracta centralis pulverulenta. is an embryonic nuclear cataract. It is congenital nuclear cataract. It has dominant genetic trait and occurs due to inhibition of lens development at a very early stage and thus involves the embryonic nucleus. The condition is bilateral and is characterized by a small rounded opacity lying exactly in center of lens. Opacity has a powdery appearance. Pallurulunda. Pallurulunda means powdery appearance. Usually does not affect the vision. Lamellar cataract. Lamellar or jonular cataract refer to developmental cataract in which opacity occupies a discrete zone in the lens. It is the most common type of congenital cataract presenting with visual impairment. It occurs for 50% of the cases. It may be either genetic or environmental origin. Genetic is usually familial autosomal dominant variety. Environment for vitamin D deficiency, hypocalcemia. Sometimes maternal rubella infection contracted between 7th and 8th week of gestation may also cause lamellar cataract. Characteristic features. Typically, this cataract occurs in a zone of fetal nucleus surrounding the embryonic nucleus. Zone of fetal nucleus surrounded by embryonic the mean mass of lens internal and external to zone of cataract is clear except for small linear opacity like spokes of wheel riders which may be seen towards the equator. Occasionally two such rings of opacity are seen. It is usually bilateral and frequently causes severe visual defects. Sutural and axial cataracts. Sutural cataracts are comparatively of common occurrence. It is seen by oblique illumination in optical section with the beam of slit lamp respectively and around the anterior and posterior eye switches. Such cataracts are usually static, bilateral and do not have much effect on the vision. It consists of punctuate opacities. The individual opacity vary in size, shape, have different pattern, thus are named accordingly as follows. Floriform cataract. Here the opacity are arranged like petals of a flower. Coralliform is characterized by anterior posterior spindle shaped opacity with offshoots giving an appearance resembling coral reefs. Like spear-shaped cataract, lenticular opacities are in form of scattered heaps of shining crystalline needles. Anterior axial embryonic cataract occurs as a fine dot near anterior eye switcher of fetal nucleus. The dendritic sutural cataract occurs as fine dots along the dendritic sutures. Fourth one is total nuclear cataract. It usually involves the embryonic and fetal nucleus, sometimes infantile nucleus as well. It is characterized by dense, chalky, white central opacity, seriously impairing vision. The opacity are usually bilateral. Bilateral and progressive. Then fourth one is generalized cataract. Coronary cataract is an extremely common form of developmental cataract occurring about puberty. Coronary cataract. Coronary cataract as seen by oblique illumination in optical section with beam of slit lamp as per clinical photograph. This involving either adolescent nucleus or deeper layers of cortex. Next one is the opacities are often many hundreds in opacities are often many hundreds in number and have a regular radial distribution in since the opacity are situated in peripheral, vision is usually unaffected. Sometimes the associated large punctuate opacity may marginally reduce the vision. Blue dot cataract punctuata. Perhaps this is most common type of congenital cataract. It usually forms in first 2 decades of life. Total congenital cataract, it may be unilateral, bilateral. Rubella cataract, maternal rubella infection occurred during first trimester. Rubella cataract, typically the child is born with a pearly white nuclear cataract. It is a progressive type of cataract. Lens matter may remain soft or may even liquefy. In cataractous nucleus may harbor the virus up to 2 years of age. Therefore, removal of such a cataract is usually followed by severe inflammatory reaction, uveitis or even endophthalmitis. Note rubella syndrome. The classical rubella syndrome consists of ocular features: congenital cataract, salt, pepper, chorioretinopathy, microphthalmus, cloudy retina, poorly dilated pupil, ear defects, heart defects, etc. Congenital membranous cataract is also one of the cataract. Differential congenital cataracts presenting with leukocoria need to be differentiated from various other conditions presenting with leukocoria such as retinoblastoma, retinopathy of prematurity, persistent hyperplastic primary vitreous syndrome. Management of congenital cataract, clinical investigation, ocular examination, density and morphology cataract, quality of red liver seen on distant direct ophthalmoscope, assessment of visual function, an idea made by density and morphology of cataract, special tests like associated ocular microphthalmos, glaucoma, BHPV, foveal hypoplasia, laboratory investigation, interrogative investigation, galactosemia, Lowy syndrome, hyperglycemia, hypoglycemia, prognostic density of cataract, unilateral, bilateral, time of ocular defects, and systemic defects. In surgical procedures, SICS, surgical technique, correction of pediatric aphakia, children about 2 years can be implantation posterior chamber intraocular below prevented by extended pediatric IOL size is may be standard. Bag design IOL should be present in foldable IOLs made of hydrophobic acrylic material. Previously 1 piece PMMI power of IOL below 2 years and under correction with 20 years. We'll see about acquired cataract in third part of video.